Welcome to Rock the Recovery podcast. I have a very special guest with me today. I'm very excited to introduce you to or reintroduce you to Dr. Shav. Dr. Shav, welcome to the podcast.
My name is Shavelson, so it's Dr. Shave, but Shav is good
Shane.
too. It doesn't matter. Thank you for inviting me. I think this is going to be a wonderful experience, not just for both of us, but for all the attendees.
Sure. Absolutely. I'm very excited to have you on. We've been talking back and forth on LinkedIn for a long time. I could tell right away that you are an expert in your field, and I knew right away I had to get you on my podcast because I think there's a lot of physical therapists out there who could learn a lot from you. And why don't you start by telling us a little bit about your background, and then we'll talk a little bit about what we're going to chat about today.
Okay, I'll try and keep it short. Uh, I'm
Okay.
s- I'm an old man, and I spent most of my life as a board certified foot and ankle surgeon, including being the chief of podiatry at Mount Sinai Medical Center in New York City and a residency director. And at some point, when they asked me to bring my surgical packs to the autoclave so that I can get them ready for the OR, I decided that I was no longer being catered to, and I went into
Well,
private practice, and I went in direct pay or cash only, no insurance or out of network, however you want to call it in those days. Started a practice in the financial district, which when COVID hit, all of my clients who were big pharma and finance and banking started working from home, and overnight my building was boarded up for 4 months, and that was the end of my practice. And
hmm.
so I, at that point, did what my family wanted me to do, was get out of practice and go
Mhm.
down to Tampa, Florida, where two of my five kids and four of my seven grandchildren are. And now instead of doing bunion surgery, I'm throwing baseballs and dolls at kids. So it's been a very good trade-off. But all
I
my
was gonna,
career, I have worked as a mentor, and not just teaching residents in podiatry, but in working with two main topics, which are biomechanics and closed chain kinetics, which have to do as the basis or foundation of human movement. And I feel that in 40 years, in the last 40 years, we did nothing but degenerate the consensus that we had in the 80s about biomechanics and orthotics and things of that nature. And now we have 100 different experts who are telling everybody that if they take a weekend course with them, their life is going to be blissful from then on. And then you have 99 other people saying you made a mistake, and we've lost consensus. So my purpose of being involved here now is to see what we can do to kindle some consensus that we can grow on, because that's how science, works and grows.
I completely agree with you. And I think, when you talk about the foot and, the closed chain and the biomechanics of ground reaction forces and walking and, I think it's an art form. It's a thing of beauty, really, the way the foot works and as we stand and walk and balance on our foot. So, I completely agree with you. And I think there's a lot of physical therapists who, like I said before, who could use that consensus and have a better idea of how to attack the foot and how it affects the kinetic chain all the way up to the spine. So I would love it if you would go through and kind of talk to us a little bit about how you evaluate the foot. Someone comes in to your practice, back in the day and said, I'm having foot pain. Tell us a little bit about that. I read your article on foot centering technique, and there's a lot involved in that. So,
There certainly is.
yeah.
I appreciate the introduction and the opportunity. I'll start by saying that Da Vinci was correct when he hundreds of years ago said that there's two things that make us the king of the animals: our brains and our feet.
Mhm.
And holistically, that what I think we're all trying to do is connect the two. And I'll start by asking the audience or anybody listening, and yourself if you know what a Babinski reflex is. And what it is a reflex that exists when the spinal cord is broken or when the connection between the brain and the foot is lost. And most people who are educated about Babinski know that the Babinski sign, unfortunately, exists in us for the first 3 years of life, relatively. And what that means is that for the first 3 years, our brains are not connected to our feet. And so trying to teach anybody anything at that point, a 3-year-old horse wins the Kentucky Derby and a 3-year-old kid can't kick a soccer ball and stay on his legs. And so there are 5, what I call the harmonies of life, S, 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 B, and that's stability, support, strength, symmetry, and balance. And those 5 things come into play at the age of 3 when our feet are finally connected to our brains and how we learn to task. So if I want to walk, I have to lift up one foot and create an imbalance. I have to take my center of gravity forward. I have to go into a fall, and my brain and feet and the entire chain have to learn how to control that fall. And I can check the box that I've learned the task of walking, and I do that with the remainder of tasks that I learned throughout my life. And so what my treatment is based on or purposeful is in diagnosing. In other words, somebody comes to me with a chief complaint, and I'm not concerned with the chief complaint. I'm concerned what their functional foot type is, what their body is like, what their activity aims are, what their weight is, what their kids do. I'm concerned with their life and lifestyle and how I could entertain intervening in a positive way and educate and treat them to success. So that started with my first patent, which was a foot typing methodology analogous to blood typing, where years before we were giving people transfusions and watching 2/3 of them die. And now that we invented blood typing, we can define what your blood type is and give you aggressive care for your type of blood and not make the mistakes or do things that would harm other people. And so my foot typing methodology is the diagnostic starting point for foot centering biomechanics. And when someone asks me questions about closed chain function and biomechanics, I only have one answer, and that's what's the foot type? Because if we want to talk about 1,000 feet of various types, we're never going to get any research. We're never going to get any articles that are going to direct us, because you have to know what foot type you're going with. So that's sort of the starting point. And once you know that foot type, you can then let's say if you're talking about kinesiology taping or ultrasound or manual therapy or Graston technique or whatever, you would have to know what to do for that foot type or the posture that's sitting upon that foot type. And that's sort of where we gain consensus.
So tell us a little bit about how you come to find the foot type. So I know from reading the article, it talks about an
You mean
assessment of the rear foot and the forefoot.
the actual
Oh,
technique?
well, you know, what do you,
Foothelpers.com or any ResearchGate, Dennis Shavelson, ResearchGate, Dennis Shavelson. There's 20 or 30 published articles, and there's stuff on functional foot typing is the name of the patent.
Mhm. Okay,
We
very
we
good.
have other things to talk about here.
Good, good. Um, yes, that's true. And you know, I like I said, I read your article. You know, you did, you know, you hit on all of those things in those articles. And you know, it's very interesting listening to you know, the how systematically you broke it down. So I definitely recommend it. And if you're okay
Yeah,
with it,
I'll just give a high arched Cavus foot is attached to a tight, high arched, stiff and non-flexible posture, and it functions that way. And in treating that client, we actually would like to make the foot more flexible and less rigid,
Mhm.
compared to any one of the 2 or 3 flat foot types, where we want to strengthen the foot and raise the arch and strengthen the foundation, the stability, support, and balance at the level of the foot, so that the rest of that flexible posture can adapt and function. So that's sort of the reason why.
Oh yeah, you summarized that article very well in a short period of time. That was perfect. Obviously, you wrote it, so you probably are pretty good at that. But um, so you've taken that information. You have a patient come in. As a physical therapist, we're always looking to have more tools in our tool belts, and I think your article definitely. Really, like I said, compartmentalized everything in a really nice way, and really kind of drives your treatments in a really good way. And I appreciated that. So,
The other important thing is that, all of our work, in my estimation, is qualitative. And
mhm,
as scientists and I guess I would say medically trained people, we always want to quantify. We want to be exact. Your blood sugar is 123, and if it was 122, you have diabetes. I'm being silly and metaphoric, but in the way
no,
we're
you're right.
talking, in Newton's 3 laws that started, I guess, all engineering out, it works in a vacuum, and we're not in a vacuum. And if you took 3 items of the same mass, a bunch of feathers, a piece of gold, and a bird, and dropped them from a tree, the bird can fly away. And so we don't follow Newton's law. Nature does not follow the engineering of a piece of wood. You
Right.
roll me
Yeah.
in a snowball down the hill, and I could either stop, go faster, or go slower. So,
Mhm.
we are dealing every time with a client or patient who presents with a broad range of variables, that one treatment method, everything has, the more we customize. And I'm sort of going to change what you said in terms of a tool belt. I talk about a toolbox, and maybe we should have a tool trunk. We should never stop educating ourselves and
Mhm.
preparing ourselves for that one client who comes in, that we now can open up our toolbox and say, I've only seen 2 of these, young lady, but I have the opportunity of maybe being as smart as anybody else in how to handle it, and I'm going to use these tricks in my toolbox.
And like you said, it's qualitative. I mean, you can try to compartmentalize everyone as much as possible, but really what it comes down to, every person's a blank slate, right? So, you're looking at the whole system, and so everyone's situation is going to be slightly different, right? So,
And within that person, I gained 30 pounds. I decided to run
Mhm.
6 miles instead of 3. I got a new job. I just had a kid. I got cancer.
Mhm.
I banged my foot, or I hurt my knee, or there's
Mhm.
it's I guess what I tried to do is make the only variable. It's interesting, Rob, you're opening up subjects that I don't often talk about, but I guess it's
Okay.
wonderful.
Yeah.
There's 2 ways of examining and researching people. One is called deterministic, and the other one is called stochastic. And in deterministic study, it's quantitative, and we eliminate all variables. We had a COVID epidemic, and for a year and a half, we couldn't give the vaccine to anyone under 18 or a pregnant woman, not because the
Mhm.
vaccine didn't work, but they weren't included in the existing cohort, so that the statistics would come out appropriate. And so thousands lost their lives, and until we then said, okay, we've now done a study on pregnant women and kids, and now you can
Right.
use it too. So
Mhm.
in stochastic study, you maintain all variables, you don't create outliers, in deterministic study, there are outliers, and those are actually patients or clients that need us the most, and they're eliminating them from the study because it would ruin their data, their findings. So all of my work is stochastic. I've even written articles on why we should or study biomechanics stochastically. And the only variable I have is what's your foot type. So if I take 1,000 people of one foot type and let's say study their plantar fasciitis complaint and what I can do or should do for it, and if the outcomes come out positive, I have now created a therapy for treating somebody with that foot type who has that complaint. If I take 1,000 people of varied foot types and do the same thing, I come up with no answer.
I,
Instead of looking to create, we have lots and lots and lots, our heads are bursting with new data and new
mhm,
experts who can take that data perfectly, but nobody knows what to do with the data. And the reason
mhm,
is that we're studying things deterministically. And so when if you're looking at a force plate and that's checking your kinetics, um, they have a force plate, and what their goal is to take something called the center of pressure, which can deviate and be abnormal, and
mhm,
take it and make it normal. And so the theoretical outcome of an intervention that makes your center of pressure more normal is that that's going to help your complaint. I hope I'm saying that right. And in
right,
reality, they have no proof that fixing the center of pressure does anything to help knee pain or back pain or plantar fasciitis or an ingrown toenail. And so all of my stochastic work is dependent on tell me what the outcomes are the day after you did it, 2 weeks
mhm,
after. So we have to have a way of monitoring the outcome and the
mhm,
functional improvement, and not whether or not their pain on the bottom of their heel is better, but whether or not they have better stability, better support, better strength, better symmetry, better balance. And that's what my work does.
mhm.
My device is guaranteed to improve the five harmonies and not necessarily cure, I don't know what, plantar
Right.
fasciitis or cancer. That was a joke.
Sure. I mean, it ultimately will, it's obviously going to help all those things also. I mean, not so much cancer necessarily, but, if you look at the plantar fasciitis, I mean, obviously it's going to resolve based on fixing those five uh, key points, right?
Well, one of the things that I've done is trying to convince. I have physical therapists who tell me that pelvic rotation or an offset hip will make feet flatter. And in reality, we're talking about gravity and ground reaction force as being the major things that our body overcomes. But they're also the most wonderful things that have side effects that are not, I don't know what you'd say, that some at some point break down the machine and eventually stop the machine from working. I laughingly say, I start this segment by laughingly say about 2 months ago, I opened up an office on the moon, and I had to close it after 4 weeks because no one ever came. So if we don't have gravity, we don't have contact with the ground that gives the
Mhm,
ability to push off the ground or jump off the ground or cut or move off the ground. And yes,
mhm,
as you do that, there are certain breakdowns. There's shear, there's friction, there's aerodynamics, there's all kinds of things that we have to deal with. But if we were on
mhm.
Jupiter, with it's 3 times the size of Earth's gravity, we would be 2 feet tall, 5 feet wide, and stuck to the floor of Jupiter. So fortunately,
Right.
we have to be thankful that we were born on Earth with its gravity and its oxygen and water and all the other things. But the called plantar fasciitis, bunions, neuromas, shin splints, these are all a reaction of one major machine that exists at the forefront of the foot, and that's the bunion joint, and I call that the kickstand of the foot. And once we acknowledge that there's a kickstand of the foot that's either working or broken, when it's working, we can cause two bones between a joint to become rigid and tight, so that we call it the rigid lever phase, and it can
Mhm.
become more loose and flexible, and we call that the flexible adapter phase. But if and when that kickstand is broken, the side effects become bunions and aromas. And so the plantar fascia is a ligament that starts in the calcaneus medially and goes into all five metatarsals, and it engages the bio kickstand. And so if that kickstand is not engaged, instead of pulling on the front of the foot, it actually, the kinetics change so that it's starting in the foot and it's pulling on the medial aspect of the heel, and that's plantar fasciitis. So once I diagnose that the kickstand is broken, which is a simple diagnosis made by x-ray or examination, I now can engage or fix that kickstand, and that eliminates the pain or the plantar fasciitis. The example I give is that if you had a tire that had no air in it and it had three broken spokes and a bent rim, and you now put some air in the tire, you would still have a broken tire. And so most of the complaints that we have are things that work for or are acted upon by the kickstand. And 70% of us have a broken kickstand. And so that becomes
No, did
the
you
basis for
deliver the furniture?
biomechanics.
I did, and when I
Yeah, I definitely agree with you on that point that the kickstand is crucial. With toe off and in the gait pattern and
No,
mid
no, not
stance
in
through toe
toe
off.
off, not in toe off, in every
No?
functional thing that we do, every time I
Okay.
stand.
Okay.
The analogy here is that if you had a Harley Davidson that has a front wheel and a back wheel, just like we have a rear foot and a forefoot, and you want it to stand independently, you cannot do that until someone lowers its kickstand. And the same thing happens in the foot thousands of times a day as we task and move. When I'm cutting, that kickstand has to be tight. And then as I start to move to the left or the right, it has to be flexible again. So it's way beyond gait pattern. It's way it's in every. I make a device that helps you in life, not in gait or in walking or in running or in lifting or whatever. I'm sorry I
Mhm.
had to interrupt you on that.
No, no. Thank you for correcting me. You're absolutely right. With that as well. I wanted to circle back to something you were talking about earlier about shear forces and the kinetic chain up to the knee and the hip, and you got me thinking about something because I work in a nursing home. I work with patients who are 80, 90, 100 years old, and as you can probably imagine, I see some significant deformity from the valgus at the knee, tibial rotation down through the foot. And my question to you is, is there an age where we have to kind of not not treat that problem, but reconsider how we approach it? I mean, or do you think you can take your techniques and use it on any age?
Okay, I hope I'm answering a question. I hope it's the question that you're asking because it's sort of convoluted. I work at the heart of our treatment methodology is a two-word concept, and that's purposeful longevity. That happens at 3 when the Babinski sign decreases, and it ends at death. And at 20 years of old, you're thinking I'm going to live till 100, but at 80, I don't want to start using a cane, and I don't want to I don't want to get diabetes and genu valgum and look at Rob Kleinberg. I don't ever want to do that. So if we use that, I used to work on fall prevention, and all I was doing was keeping the person without purposeful longevity and keeping them from falling, and they still needed their crutches and they still needed their canes. And so I eliminated that. There's what we would call salvage or heroic work. that has to come when somebody is past the point of general, what I would call universal care, but almost
Right.
at any age. For instance, if somebody doesn't have enough power to squat off of a couch that's too low and they can't get up without using their hands, I start
Mhm.
them at sitting at a desk that's 3 feet tall instead of 2 feet tall, and have them get up and down from there without using their hands. And a week later, I lower the desk and I lower the height of it until they're down. And the last thing a person wants to do is not be able to get off the toilet when they're finished. So that would be purposeful longevity. And
Mhm.
I have exercises and programs, I have tools and services that allow us to do that. I own my own kinesiology tape, which is extra strong and capable of being stretched 100%, so it can keep something stable and balanced. I own my own device lab making dynamic foot braces. I have patented my own methodology. And so if you ask me any particular question, this is sort of maybe in future podcasts, we can start carrying those things. But I have six 1 hour lectures that cover the entire subject that I guess fortunately or unfortunately for me, there are small fees involved, but I think they're approachable. And if anybody explains to me why they can't approach the fees, I do it pro bono. And that's how I've always worked, even with patients. Um,
Mhm.
so I'm prepared to give and offer people once they can get past the thought of I don't know what, I'll use something that I find for most physical therapists. The podiatry profession 15 or 20 years ago started a 3-year surgical residency, and now we're preparing unbelievably capable surgeons using high-tech, instrumentation and tech and coursework and skill work, except they've lost the idea of making of biomechanics and prehab and rehab. They
Right.
are, dare I say it, they are doing a surgical skill very accurately, but they believe they're capable in making the surgical decision preoperatively of what maybe there's something you can do. If you need a knee replacement and you weigh 450 pounds, any surgeon worth their grit would tell you, I'm not working on you unless you lose 100 pounds because it's not going to
Right.
work. And
Right.
so that becomes the job of the physical therapist. And
Mhm.
afterwards, I put them in a cam walker or a black surgical shoe, and I can do so much more, for 6 weeks and watch their muscles atrophy and watch them forget how to walk and play
Right.
baseball and do these other things. And now that becomes a source of smart referral to a smart physical therapist who would then refer back those cases where they can fix something that they can't fix and then send them back to the physical therapist. I think all the
I would,
podiatrists listening have just shut off, but that's okay
yeah,
by me.
I would love to have another conversation with you a different time about boots and orthotics. I mean, like walking
Well,
high
what
tie
happens
boots.
is the podiatrist has maintained the $600 profit that's built into an orthotic. And so you're getting that referral when either the patient's unhappy or the podiatrist doesn't know what to do for them. And
Mm.
instead of having a planned rehab that they could, that was done in a team way with other professionals. Um, and now this is what I was leading to. Most physical therapists tell me that podiatric orthotics are worthless because they really don't do anything. And so when you refer them to me with an orthotic already, I can't say, I'm sorry, this orthotic's no good. We have to make you a better one, or I have to give
Right.
you a different treatment than they offered, because then you're going to make the patient think this wasn't a good surgeon. So
Mm.
there's a conundrum here, but in reality, I am teaching I'm eliminating the need for a prescription to make a foot insert. Right now, custom orthotics are made by a prescription. And so if you don't have a prescription pad, you can't make a custom orthotic. My devices are called dynamic foot braces, and they're made by a work order, and you have to be certified in my biomechanics, which is pretty seamless. And at that point, the physical therapist can make the $600 on the orthotic, and the surgeon can make his surgical fee. And I don't know what, the brace maker,
Sure.
in other words, it would normalize things and change the
Yeah.
importance of specialization.
Thank you. Well, Dr. Shave, I hate to cut us off, but I think we're just out of time at this point. But I'm definitely going to put the links to your articles and your website on the comments below. So thank you so much.
Okay, I welcome the opportunity to do this more, and I don't know,
Yeah,
I'm very active on LinkedIn and would love new connections and people who are interested in working with me. And I want to congratulate you on your recent change of employment. You have left
thank you.
us all health and security and good stability and balance.
Thank you. Yes, yes. I need all those S's and B's. I appreciate that in
Okay.
life. So, all right. Thanks, Dr. Shave. I will do this again soon. Okay.
Yes, bon voyage.
All right. Bye now.
Bye.